Welcome to our in-station training program. Today we're going to be discussing central venous access devices, also known as ports. I'm Stephen Jacobson and I'm going to be narrating this program for today. The objectives for this presentation are to define a central venous access port, identify their purpose and use, discuss some of their uses in the pre-hospital setting, go over the procedures for accessing the device, and also some considerations for the decision-making process when you're faced with one of these in the field. Most of us have run into a central venous access port before, but either didn't know it was there or didn't really know what to do with it. It's called a lot of different things depending on who tells you, be it different providers, patients, their family, sometimes known as an A-port, a power port, portacath, a Mediport. Some of these are name brands, some of these are specific features of the device, and some are just, what someone's used to calling it over the years. Either way, all these terms describe a surgically implanted subcutaneous venous access device with a reservoir. It is implanted under the skin with the catheter placed in a large central vein. The people we encounter who have a port are usually those who require multiple medical treatments or are sometimes pretty sick. They can have this for multiple venous accesses for medications, for parenteral nutrition for those who can't eat in the normal way, for blood product administration, or multiple and repeated blood draws. Having this port decreases the anxiety related to multiple peripheral needle sticks. It also decreases the infection rate that you usually find when you have multiple peripheral needle sticks. It's also, since it goes right into a central vein, decreases venous irritation with some medications, for example, chemotherapy medications. And the main purpose really is to have long-term placement of central venous access. Depending on the manufacturer, these devices can be constructed in many different manners. Some are made of plastic, some of stainless steel, some of titanium. They also come in single or dual chamber models, and the reservoir varies in height and size. The length of the catheter varies and is made of some sort of biomedical material. The length and diameter is based on how much needs to go through it, the size of the patient, and how far it has to be inserted. There's also the specific one called power ports, and those are able to sustain high pressure infusions. Here are some examples of the power ports. The one on the left is a single chamber. As you can see, it's about the size of a penny. The one in the center has two chambers or two reservoirs. And if you look at the right, the X-ray, it shows it in the patient's chest. And you can see the small catheter that goes up into one of the patient's central veins. There are risks associated with the ports, not only with the implantation of it, but every time it is accessed, and pretty much just from having it placed in the patient. One of the main concerns is bacterial infection. A bacterial infection can clog and or compromise the device. When this happens, the device has to be removed, and another one has to be inserted. Another problem can be thrombuses. A thrombus can prevent flow through the device. It can be prevented by flushing with saline or heparin as prescribed by the physician on a regularly scheduled basis. If there does end up being something blocking it, this can be corrected in the hospital setting using clot-busting medications, but in the pre-hospital setting you're not able to correct it at all. Another risk is mechanical failure. It's very rare because the septum is made of a self-sealing silicone, and it can withstand hundreds of punctures before it becomes weakened, and usually the device does not fail, but it has been known to happen. Another concern is anatomy changes. This occurs mainly in children as they grow. The placement of the catheter can change as the child grows larger. It can also change depending on how a person's anatomy changes as the disease process affects them. And probably one of the concerns that I think most people think of is pneumothorax. This can be a result of inserting the device or accessing the device because you really are sticking a needle into the patient's chest. But it's not really a concern if it's done properly. As with any medical procedure that we do, you should use caution. The port is not only a device that is used for central venous access. There are also devices that are very similar and look similar that are in place for people with the lap band procedure. These are usually found in the abdomen versus the chest, but it still is a port under the skin and it is used for adjusting the lap band inflation levels. This does not connect to a central vein, and it only has a small area for you to put fluid in to adjust the pressure of the lap band. There also can be ports or tubing hanging out from a patient that can be used for peritoneal dialysis, peritoneal chemotherapy, and many other purposes that are not IV access. So now the point of this whole presentation, the pre-hospital use of this device. This is for patients who require intravenous access and peripheral access is unobtainable. All medications and fluids that we carry can be administered via this route. Patients with ports generally have them because they have a need for reliable IV access or they have a severe difficulty gaining peripheral IV access. Maryland Medical Protocol has guidelines and procedures for accessing central venous access ports on page 165 of the 2011 protocol book. In there it says that paramedics can access this to initiate life-saving interventions without medical direction. Medical direction is required to access a port for non-life-threatening situations. CRTIs, EMTIs require online medical direction for all scenarios requiring access of the device. Included also on that page and subsequent pages are step-by-step instructions on how to access a port. Before accessing a central venous access port, you have to kind of consider some of the other things out there. In the field, the risk of infection is much higher versus the hospital or in medical offices where sterile field and proper sterile technique can be used. You also should consider, does the patient need immediate IV access? Some providers also don't do this very often and may not be comfortable with the skill, or they may not be proficient in it as well. Each provider should weigh the options in each situation. They should consider peripheral access, intraosseous access, and or central venous access depending on what they are presented with at the time. I've broken down the procedures for accessing this device into 5 basic groups of steps. The first is identifying, second is to prepare, third is to access, fourth is secure, and fifth is then to use the device. I'll go over each one of these steps in the subsequent slides, going over step-by-step instructions as well as detailed information and pictures as needed. The first thing you need to do is to identify the site. These ports are frequently located on either side of the upper chest. You should palpate the area to locate the septum. It's usually a round shape and the reservoir. These shapes can vary depending on the brand and manufacturer. Every time you go to access one of these, you should inspect the area for redness, edema, pain, or drainage because those can be signs and symptoms of a problem with the port and may make the port non-usable at the time. You should also confirm with the patient, family, or medical records what the device is prior to accessing it and administering IV medications or fluids. Your next step in this process is to prepare your equipment. You need to prepare your Huber needle, a needleless port, at least 2 saline flushes, an empty syringe for blood draw if you're going to do that, and chlorhexidine or similar antiseptic device. You also need some sterile gloves to do this. While preparing the equipment, you need to make sure you maintain the sterility of the equipment and prepare the needle, needleless port, and prime the Huber needle with saline. Once you've primed it with saline, you need to clamp the tubing shut that is connected to the Huber needle. In the previous slide, I mentioned the Huber needle that you use to access these devices. This is the 90-degree non-coring needle. These are manufactured in a way so that it can puncture the silicone without damaging or removing the material. That's the non-coring part of it. These are made so that you can access the device over and over many times. If you use a device other than the non-coring needle, it risks damaging the septum of the device and prevent it from sealing back up when you remove the needle or when someone else at the hospital removes the needle after it's done being used. Your next steps in the preparing the site group of steps is infection control. You need to wash or clean your hands, put on clean gloves, and then place a mask on the patient and the provider that's going to be doing it. You need to make sure you clean the area using an appropriate solution, which would be chlorhexidine or similar antiseptic, and allow it to dry completely. After this is done, you want to don sterile gloves and make sure you maintain a clean technique while doing so. When you access the device, you want to take one hand, usually your non-dominant hand, and place it on the patient's chest to stabilize the device. Using your dominant hand, you need to hold the Huber needle firmly and puncture the skin and septum of the device in one motion. After you've done that, you need to aspirate blood and check for blood return. You're going to unclamp the tubing, use the flushed syringe to draw back blood and see if you get blood return. If you're going to be drawing blood to put into blood tubes, you want to make sure to waste at least 5 to 10 milliliters of fluid and then obtain a new sample with a new syringe. After you've drawn off and you've gotten blood and you've taken that syringe off, you're going to take saline flush and flush the device with 10 to 20 milliliters of saline. Never force flush if resistance is met. Once you've accessed the device and made sure that it is patent, you need to secure it. You need to cover the entire site with a bio-occlusive large enough to prevent contamination of the needle or the site that you're accessing it. Then you need to connect and secure the IV tubing to prevent dislodgement during patient movement or use of the device. After you've completed all these steps, you can now use the port. You can administer IV fluids and medications through it as you would through a peripheral IV. One consideration to be aware of is that this medication will be delivered pretty close to the heart. You should be cautious when giving things by IV push to make sure that you don't push them too rapidly. You should also make sure that you do not de-access the device without the proper training or equipment. Some contraindications to either accessing or using a port are when you look at the site and it appears infected. Those could be redness, swelling, heat, drainage, or pain reported by the patient. You also should not use it if you have no blood return, if you're unable to easily flush the port. These could indicate thrombosis, device failure, or improper access. The complications resulting from that could be life-threatening. When comparing a port with other devices, the port is designed for repeated use over a long period of time. It is also designed to be stored unused for extended periods of time as well. The port should be flushed at least every 30 days when not in uses. But you also don't have to worry about dressing changes like central lines because there is no dressing to change since it is subcutaneous. It's nearly hidden and it is placed by a physician, an interventional radiologist, or other trained healthcare provider. So in conclusion, I'd like to review some of the points brought up during this presentation. These central venous access devices are found in many patients in our population. The port can be used safely and rapidly, and the risk is low when the provider is educated and properly trained on how to do it. It provides a route of access for patients who may not have adequate peripheral IV access, and it could be used for life-saving interventions. I want to thank you again for participating in this presentation. Up here I have the work cited and some of the locations that I found some of the images I used on. If you have any questions or need any further information, please feel free to email me at my email address that's listed right there. If you're participating in this as a part of in-station drill, you'll get a copy of the 10-question post-test to take, as well as a supervisor or training provider who will be by at some point to do some little hands-on training with you. Again, thank you very much and have a good day.